Hi, everyone. Thank you so much for joining us this evening for Understanding Breast Cancer Recurrence Risks, Realities, and Research. A lot of ours. We are honored to have Dr. Bashir Sakr as our presenter this evening to kick off our Breast Cancer Awareness Month virtual series. We have a few events throughout the month, so I hope that you will be able to join us for all of them. If this is the first in our series, we will be using the Q&A box for any questions, so we'll save time at the end to allow for questions. So we will be using the Q&A function, not the chat. So feel free throughout as questions come up to type them in the Q&A, and at the end I will moderate those questions and ask Dr. Sakr to take our questions. So with that, I wanted to offer a warm welcome to Dr. Sakr. Thank you so much for joining us, and I will turn it over to you for your presentation.
Thank you, Simone. Welcome, everybody. I hope that you find tonight's presentation instructive and informing. I tried to make it as non-technical as possible. Unfortunately, we cannot take questions during the presentation, but please feel free to enter your questions in the chat, and then we'll have time to answer some of those questions, or hopefully all of them, towards the end. So I'm going to start with a malfunction, it seems. Okay. I'm going to start with a real-life case. This is a patient who, around the age of 55, was experiencing some back pain, which started to linger over weeks after weeks. Then she went to her primary care physician, and initially was treated conservatively with mild painkillers, some exercise, referred to physical therapy. But over the following few months, the pain persisted and even got worse. So she went back to the primary care physician, had an MRI of the spine, and the MRI showed that there were worrisome lesions in the spine. She was then referred to have a biopsy, had a biopsy of the spine, and the pathology results showed that there was breast cancer in the bony spine. So, going back 9 years before that, Jessica was 46 years old when she was diagnosed with cancer in her breast. The cancer was only in her breast. It was diagnosed at stage 2. Her treatment included surgery to remove the tumor, and then following that, she had radiation therapy and took pills, anti-estrogen pills, tamoxifen and anastrozole, and until recently, she had been perfectly fine. So what happened? How did this happen? Again, if you look back, when she was diagnosed with breast cancer, she had a lumpectomy. The entire tumor was taken out. They took out some lymph nodes. The lymph nodes were clean. So after the surgery, she was completely cancer-free. She was prescribed the pills, and she took them faithfully. She might have skipped a dose here and there, but for 7 years, she took the pills regularly. Every year, she went for her mammogram, and she lived a healthy lifestyle. So why did her breast cancer recur? And what is recurrence anyway? So recurrence is when someone is diagnosed with breast cancer, they are treated, and after treatment, they are considered cancer-free because all the cancer has been completely taken out. So how and why does recurrence occur? What are some of the factors that increase the risk of recurrence? What do we try to do to prevent it? And can we do better? But first, let's start with some basics about breast cancer. This, you can see, is the anatomy of the breast. It is primarily, there's a large number of lobules that are arranged in groups that are called lobes. And this is where the milk is produced. And milk then is channeled some distance to the outside through the nipple. Most breast cancers start within these milk ducts. And if you look at a cross-section of one of these ducts, you see that this is a normal lining of the duct. But at some point, an abnormal development happens, and these cells start to grow and accumulate inside the duct. Excuse me. As long as they accumulate inside the duct and do not have the ability to grow outside the duct, this is a cancerous growth, but this is what we call ductal carcinoma in situ. Carcinoma means cancer. Ductal is referring to the fact that this is within the duct. And in situ refers to the fact that they stay within the duct. They do not go outside the duct. But over time, these cells can become even more abnormal, and they develop the ability to grow outside the duct. And this is abnormal behavior. And to make things worse, these cancers can move around and even travel. So a similar phenomenon can also happen in these lobules. And when that turns into cancer, we call this invasive lobular carcinoma as opposed to invasive ductal carcinoma. So this is a depiction of when the cancer has gone to a certain size that a mammogram can actually see a lump in the breast. And you can see here also some shadows that represent the lymph nodes. You can see it here on this illustration, where the tumor and those lymph nodes that drain the tissues, the lymphatic tissue from the breast. So at some point, certain cancer cells can detach themselves from the primary tumor and migrate into the bloodstream, where they travel through the blood, and at some point they exit the bloodstream and they go into the tissues. And breast cancer particularly, when this happens, preferentially these cells go to the bones, to the liver, to the lungs, to the lymph nodes, and occasionally to the brain and ovaries and other organs. So a little bit on the treatment of early stage breast cancer. So early stage breast cancer is cancer that has not yet metastasized that we can tell. So it's somebody who comes in with cancer in the breast, maybe also in the lymph node, but no sign of cancer outside the breast or the lymph nodes around the breast. And the treatments here are primarily surgery to remove the cancer from the breast and sometimes lymph nodes. In addition to that, we use other treatments like radiation therapy and some medical therapy. When it comes to surgery, the treatment is sometimes mastectomy, removing the entire breast, but most of the time it is a lumpectomy where the surgeon removes only part of the breast that contains the tumor. In addition to the mastectomy or lumpectomy, the surgery also involves removing sometimes more, but usually just a small number of lymph nodes from under the arm to determine whether or not the cancer has spread there. Following surgery, especially after a lumpectomy, the breast is treated with radiation therapy, and this is a treatment that is delivered to the breast itself, and sometimes also includes the lymph node areas around the breast. In addition to surgery and radiation, most women also are prescribed some form of medical treatment, and those, we'll talk about them a little bit more later in the presentation, include anti-hormone pills, chemotherapy, immunotherapy, and some other what we call molecularly targeted therapy. So why does breast cancer recur then? It does recur because at the time of diagnosis, when the patient is found to have cancer in the breast, where there's no sign of any cancer anywhere else, sometimes there's already microscopic cancer that has metastasized, that has spread to other areas, that is just not detectable. Currently, with current technologies, we do not have the means of finding microscopic cancer. And over the course of time, these areas where there is microscopic cancer slowly grow to the point that then they become detectable by current means such as scans or other tests. And this can happen months, years, or even decades after the initial diagnosis and treatment. Do all types of breast cancer recur? The answer to that is yes. All types of cancer can recur. We talked a little bit about DCIS, and that's the cancer that is confined to the inside of the ducts. So DCIS can recur, but it doesn't spread. It can recur in the breast itself. So in someone who's had a lumpectomy, if there were microscopic cells that had moved to other places within the breast, then yes, they can grow in the future and cause what we call a local recurrence, a recurrence within the breast itself. Invasive cancers can cause a local recurrence, but they can also cause a metastatic recurrence when they spread to other places in the body. And all types of invasive breast cancer can spread, although some of them are more likely to do so than others. So how can we then predict if someone who was diagnosed with breast cancer and treated for it is going to have a recurrence or not? Unfortunately, with current technology, we cannot know for certain if somebody is going to have a recurrence or not. We do not have any tests that are accurate enough to help us predict with certainty if cancer will or will not recur. All we can say that if anyone who has had a diagnosis of invasive cancer is at some risk of developing recurrence in the future. However, we do have ways of estimating how high or low that risk of recurrence may be. For that, we look at certain what we call risk factors. So the most common risk factors, the ones that are most helpful, is what we call staging. So staging looks at the tumor size and whether or not there's cancer in the lymph nodes and how many lymph nodes have cancer in them. The larger the tumor, the more likely the cancer is to metastasize. And the more lymph nodes, and if there's cancer in the lymph nodes, and especially more lymph nodes, then there's also a high risk of metastatic recurrence. But also tumor type can give you some information. The most common type of breast cancer is ductal, then there's lobular, and between ductal and lobular, there's really very little difference in their risk of metastasizing. But there are less common cancers, such as tubular and mucinous and others, that are much less likely to cause metastatic cancer. There's also something we call tumor grade, which is something the pathologist tells us about when they examine under the microscope the appearance of the cancer cells. And for breast cancer, there's grade 1, 2, and 3. And the higher the grade, the higher the risk of metastatic cancer. The difference between grade 1 and grade 3 is not very high, but there is some difference. And also, breast cancers come in different subtypes. For example, there are cancers that are hormone sensitive, or we call estrogen and progesterone receptor positive. And there are cancers that are hormone receptor negative. The ones that are negative are a little more likely to cause metastasis. And there are cancers that are HER2 positive. HER2 is a type of protein that we find in cancer cells. Some cancer cells have too much of it. And those are a bit more aggressive and more likely to metastasize. Also, very young women with breast cancer, less than the age of 35, seem to have a higher risk of metastatic cancer, even when their cancer is a little bit earlier stage. Smoking is also in women who continue to smoke after their diagnosis. They don't necessarily have a high risk of recurrence, but we find their risk of dying of cancer is a little bit higher. In the last couple of decades, new tests have been developed we refer to as molecular testing, and those can be very powerful predictor of risk of recurrence. Again, no test is going to tell you for sure if there's going to be a recurrence or not, but those tests have become very helpful at stratifying women who have lower risk versus women who have higher risk of recurrence. The way these tests are performed is you take a piece of the cancer tissue and you send it to a special lab, and there they examine the genetic makeup of the cancer within a very specific technique, because different tests have different techniques. And eventually they give us a report that's easy to interpret. For example, the most common test that we use in the United States is a test called Oncotype DX. And the result of that is a number, it's a score. And the lower the score, the lower the risk of metastatic recurrence, and the higher the score, the higher the risk. And this particular test is also very helpful because it helps predict if someone might or might not benefit from getting chemotherapy to lower their risk of recurrence. So what can then we do to lower the risk of recurrence in someone who has been diagnosed with breast cancer, who is at some risk of developing metastatic cancer? Well, before we get to the point of having breast cancer, if we detect cancer at an earlier stage, then the person who's diagnosed with breast cancer is therefore going to have a lower risk of metastatic recurrence. And therefore, early detection is very helpful. And that's where mammography has been shown to reduce breast cancer-related mortality. So in the communities that do mammography, compared to communities that don't, the risk of dying of breast cancer is lower, and that's because cancer is found earlier and therefore less likely to metastasize. But what we also do is what we refer to as neoadjuvant and adjuvant therapies. So in addition to surgery, we do treatments to help reduce the risk of recurrence. So we discussed this a little bit earlier. Those therapies include radiation and medical therapies. Radiation therapy is a treatment that is delivered to the breast or the surrounding lymph nodes after the surgery, and it effectively reduces the risk of local recurrence by roughly 2/3. So the person who does not get radiation therapy has about 3 times the risk of developing a local recurrence. Medical therapy are medicines. They could be oral medicines or intravenous medicines, and those are associated with lowering the risk of metastatic cancer. The choice of medical therapy depends largely on the type of the subtype of cancer we're dealing with. For example, tumors that are hormone receptor positive or hormone sensitive, we use anti-hormone pills, anti-hormone medicines, and those are very effective at reducing risk of metastatic cancer. By very effective, I mean at least 50% reduction in the risk of metastatic recurrence. Chemotherapy is helpful for all types of breast cancer, but much less in hormone receptor positive breast cancer. Immunotherapy is something that has been developed in the recent few years and has been found to be very helpful in patients who have what we call triple negative breast cancer. And those are cancers that are not hormone sensitive and they are not HER2 positive. And then there are molecularly targeted therapies. For example, women who have HER2 positive breast cancer. These are cancers, again, that have a large amount, they produce a large amount of this protein called HER2, which makes them more aggressive and more likely to spread. These are, for example, drugs that target specifically that HER2 protein. And when they combine with chemotherapy, they dramatically reduce the risk of metastatic recurrence. There are other molecularly targeted therapies. If you've ever heard on TV, advertisement for a medicine called Verzenio or Kisqali, those are medicines that can be combined with anti-hormone therapy and can help improve the effectiveness of that treatment. And there are other medicines also. But in addition to treatment, there are other things, more simpler things, that can help reduce the risk of metastatic recurrence. In breast cancer specifically, diet has not been shown to lower the risk of metastatic cancer. But we do recommend a healthy, balanced diet anyway. And there's always the question about what about soy products in patients who have hormone-sensitive breast cancer? Because soy products have been known to contain what is called phytoestrogens, so estrogen-like substances that derive from plants. The evidence so far shows that it does not matter. Eating soy products does not increase the risk of metastatic cancer if one has had a hormone receptor positive breast cancer. If anything, there's evidence that women who eat more soy seem to have a slightly lower risk of recurrence. What has been shown to lower risk of metastatic recurrence is regular exercise. There is good evidence that exercising on a regular basis lowers the risk of recurrence in women who have had and have been treated for breast cancer. In addition, there's very good evidence that women who have been treated for breast cancer experience less anxiety, less depression, less fatigue, whether fatigue related to cancer or fatigue related to the treatment of cancer, and have overall a better quality of life. Moderate intensity exercise, about 150 minutes per week, so roughly less than an hour, 3 times a week, is estimated to reduce risk of death from metastatic breast cancer by about 24%. So if you compare that to the treatments that we do, it is a very effective way of reducing risk of metastatic cancer. In some cases, chemotherapy reduces risk of death from breast cancer by 20%. So this is could be even better than that. Weight management. So it is clear also that women who are overweight are more likely to develop breast cancer, but also if they've had breast cancer and they have a high body mass index, they are at a higher risk of recurrence. Unfortunately, so far, the studies have not been able to prove that if you're overweight and you reduce your weight, you reduce your risk. Although that could be true, the studies have not been able to show it yet. So recommendations typically are to try to reduce weight if at all possible. And other lifestyle changes relating to smoking and alcohol. Again, as I mentioned that earlier with regard to smoking. If you're diagnosed with breast cancer and you're a smoker, you are more likely to die of breast cancer, even though smoking itself does not increase the chance of someone developing breast cancer to begin with. But if you're a smoker, and especially if you continue to smoke, the risk of dying of cancer, of breast cancer, is higher. So we do recommend quitting smoking to anyone who has been diagnosed with breast cancer. The consumption of alcohol is associated with a slightly higher risk of developing breast cancer. But if you've had breast cancer has been treated, if you drink more alcohol, it does not seem to actually increase the risk of recurrence. So once someone has had breast cancer and it's been treated surgically and otherwise, what do we do to look for recurrence? So for local recurrence, we do recommend that mammograms are done once a year. And for people who have a slightly higher risk of developing breast cancer, we might also recommend that they do, in addition to once a year a mammogram, once a year an MRI. For women who have dense breasts, we might also recommend breast ultrasound in addition to the mammogram. But those are means to look for local recurrence. We also recommend at least twice a year a breast exam in the office. Even though scientific evidence is not available to show that those breast exams do make a difference in diagnosing the cancer early enough, it is a very simple way of examining or looking for breast cancer. And occasionally we do find in the office a recurrence that has been missed otherwise. With regard to metastatic recurrence, unfortunately, there is no evidence that doing any tests is good enough to make a difference. I'll give you an example. If we do body scans, PET scans, MRIs, looking for recurrence in somebody who has had breast cancer and who feels perfectly fine, long term, whether we do scans or we don't, it does not make any difference in that person's long-term survival or risk of developing recurrence. Or when they do develop a recurrence, we might find it a bit earlier on the scan, but it does not give us the ability to treat them any better because it does not detect the cancer early enough. And that applies also to blood tests. To this day, we do not have tests accurate enough to find the cancer early enough for us to make a difference. And therefore, we do not recommend routine scans or routine blood tests after a diagnosis and treatment for breast cancer. So where do we stand in the United States with regard to breast cancer in general? Well, we can say clearly that over the years, the number of women diagnosed with breast cancer has gone up, but the number of women who have died of breast cancer has been going down. And you can show you some slides, some graphs here. I hope it's not too difficult. These are broken down, the different colors broken down by different ethnicities. For example, if you take white women, this is the incidence of breast cancer. So this is how often breast cancer happens. And you go from 2004 to 2020. The number of breast cancer diagnosed over these years in white women has increased steadily per 100,000 women. So this is not related to the growing population. Per each 100,000 women, there's been more breast cancers diagnosed over the years. However, the number of women who have died of this is still the incidence. This is triple negative breast cancer, and this is hormone receptor positive breast cancer. So triple negative breast cancer seems to be about the same. But if you look at the number who die of breast cancer from 1975 until 2020, the number of women has steadily declined. The explanation is, on the one hand, there's more screening, so we're finding cancer earlier, but also treatments have improved over the years. And this is a slide that combines both mortality that has been declining over the years and incidence that has been going up over the years. All right, so the effort to try to predict who may or who may not develop metastatic or recurrent cancer in the future, research is looking at better and better biomarkers. So what a biomarker is a biologic indicator that helps guide detection, prognosis, or choice of treatment for cancer. So as an example, I mentioned HER2, which is a protein that can be detected within the cancer cells. When there's a large amount of HER2, that's what we call a HER2 positive breast cancer, it indicates that this cancer has a high risk of recurrence. And it also predicts that there's significant benefit from the use of anti-HER2 directed drugs and chemotherapy. So this HER2 is a biomarker for breast cancer. And the idea here is to look for biomarkers that can predict recurrence. So this slide, I'm going to try to explain it as best I can. So if you look here on the left, these are 50 women. When they are diagnosed with breast cancer, statistically, 3 out of the 50, or roughly 5 or 6%, will have metastatic cancer already detectable. And the other women only have breast cancer in the breast or maybe even the lymph nodes. When you treat these women, then once you do the treatment on the women who did not have metastatic cancer, then statistically, some women are at risk of recurrence and some women are not, or at least some women will have some recurrence in the future, and some women will not have a recurrence in the future. The question is, how do we know? Because when we set out to treat all of these 47 out of 50 women, all of them will have surgery appropriately, but then all of them will also have some form of other treatment, even though only a small proportion of them is destined to have a problem. And when we treat them, some of those who were destined to have a problem avoid that problem, but some are treated and still have the problem. So ideally, we'd be looking for a biomarker who can tell us who are these women in yellow who we can cure with surgery alone, and therefore we can spare them all this treatment? And who are these women who, even if we treated them, they are still going to have metastatic cancer, and therefore we spare them this treatment, which is not effective, and look for some other treatment, and with research avenues and so on. So that would be the ideal biomarker, is to determine who are the women who can be spared the treatment and who are the women who do need treatment and will benefit from it, and the women who will not benefit from treatment. So I guess I already described this slide. So the search for better biomarkers. If we had better biomarkers, we could then spare a lot of women treatment that would not have been necessary because they were cured with surgery alone. And we focused our treatment on those women who are at risk of having metastatic recurrence and would benefit from treatment. And for those women who would not benefit from treatment because their cancer seems to be resistant, we would look for other treatments. So currently, research is focusing on, at least I'm going to present a couple of things that research has been working on. And these are disseminated tumor cells and circulating tumor cells, which fall in one category, and something called circulating tumor DNA. So disseminated tumor cells are cancer cells, that microscopic amounts of cancer cells in women who have breast cancer, who have had breast cancer or have been treated and do not have any evidence of metastatic cancer. But when you take a tissue from distant organs, you can detect microscopic amounts of breast cancer. For example, even back in the 90s, it was known that if you took bone marrow biopsies, you could find in 20 to 45% of women who do not have metastatic cancer, but who have been treated for breast cancer, you could find disseminated cancer cells. When you find those cells, you can, this predicts a high risk of recurrence, but surprisingly, not all women who have these disseminated tumor cells will have a recurrence. So although it does indicate a higher risk of recurrence, it does not predict 100% that these people will have a recurrence. But also, it doesn't tell us really anything about how to treat these women and who might not benefit from the treatment. So for now, disseminated tumor cells are not used in clinical practice, although some people continue to use that in research. A better way of getting tumor cells, because in disseminated tumor cells, you have to do biopsies, which are invasive procedures. A better way of doing that is finding tumor cells in the circulation and blood samples. And that is a technology that is available. And when you do find circulating tumor cells, you do predict a higher risk of recurrence. But again, not all women with circulating tumor cells will have metastatic recurrence. And also the number of women who have had breast cancer, who don't have metastatic cancer, who test positive for circulating tumor cells is low, even though some of them who test negative will still eventually have metastatic recurrence. So their utility is also limited. And also when you do find them, it does not really tell you exactly how best to treat them. So again, circulating tumor cells continue to be an area of research. And right now, although they do predict a higher risk of recurrence, they do not help us in the clinic make different choices. A more promising technology is to look for what is called circulating tumor DNA. So just to describe this a little bit, if you take a blood sample and you look for DNA, you will find DNA, free DNA, not within the cells, we call cell-free DNA, circulating in the blood. And most of it comes from your own normal blood cells. When blood cells die, sometimes some of that DNA spills into the bloodstream. But a very small proportion in people who have cancer comes from cancer cells that have died elsewhere. And there are technologies that can recognize this circulating tumor DNA and detect it in the bloodstream. So in somebody who has metastatic cancer, finding circulating tumor DNA is very common. And currently we use that to make certain diagnoses. In women who do not have metastatic cancer, but are at some risk of developing metastatic cancer, if you find circulating tumor DNA, it does indicate a higher risk of recurrence. And when you do find circulating tumor DNA, it precedes the diagnosis of metastatic breast cancer, typically by about a year. So it is a promising technology for predicting risk and early detection of recurrence. However, the likelihood of detecting circulating tumor DNA in women who have early stage breast cancer is very low because the amount of cancer that they have is usually very low. And still, even when we find it, we do not have an effective strategy of how to respond to a positive test, which tells us that this person is at a high risk of developing metastatic breast cancer. But this is, again, is still an area of ongoing research. And this is a very promising line of research. And hopefully, within the next 5, maybe 10 years, we will have better ability to detect the likelihood of metastatic recurrence at a very early stage where we can actually make a difference. So in conclusion, breast cancer is common and its incidence is rising, but due to better and earlier detection and improving treatment options, mortality is decreasing. We still need to try to be able to identify those patients who are least likely to face a recurrence and treat them with surgery and spare them any of the toxic and sometimes very toxic treatments that we do, and to try to identify those patients who are most likely to have a recurrence and focus our efforts on them, and also focus our research on them so that better treatments can be developed to especially treat those women who turn out to have resistant cancer. And emerging technologies such as circulating tumor DNA has a great potential to help us achieve those goals. With that, this is the conclusion of the presentation. If you have any questions, please put them in the chat.
Yes, thank you, Dr. Sakr. That was a great presentation, very informative. We will go right into questions because we have a few. Let me just pull them up here on my screen. Okay, I have one question about how to tell if there's a recurrence outside of things like screenings and mammograms. Are there physical symptoms other than feeling a lump that people may watch out for?
I'm just going to split that answer in two. Local recurrence and metastatic recurrence. So local recurrence, the symptoms, if there's an abnormal symptom in the breast itself, like a new onset pain, or if somebody feels a lump, then that would be an indication to try to look for a recurrence. Now, metastatic recurrence, the symptoms can be like anything. You could have pain somewhere, and fortunately, these are symptoms that are very common. So people have pain, back pain, other very commonly that turns out not to be metastatic cancer. But when a symptom seems to persist and doesn't seem to want to get better, then you seek medical attention, and the diagnostic efforts then are focused on that symptom. For example, if there's, say, back pain, as in the case that I presented in the beginning, then imaging can be done for that area particularly. And if something is found, then additional tests can be pursued, such as biopsies. Or somebody could be presenting, for example, with difficulty breathing, and you take an X-ray. And if X-ray doesn't show anything, the symptom persists, you get a CT scan. And then eventually that's how you find a recurrence, if it hasn't. I hope that answers the question.
Yes, the person that had included also that they feel when they have back pain and things like that, they feel, nervous about it. So I'm sure that's something that a lot of patients deal with, trying to parse out the cause of pain and things like that. So
It's
thank you.
true. I mean, it is difficult because, I mean, these symptoms are, again, are very common. And in somebody who has had breast cancer and it's constantly on their mind, obviously, it's hard to forget. When you have pain, the first thing that's gonna come to mind is, could this be cancer? But the reality is, it is not. Uh, it should be treated like any other minor pain, and then if it goes away from me, we're happy. If it doesn't, then seeking medical attention would be necessary.
Thank you. Another person wrote that their invasive ductal carcinoma wasn't staged or graded as far as they can remember from back in 2015. How can they find out about a risk of recurrence now?
Um, well, what year was it? 2015, did you say?
Yes.
Okay. So there should be records. If the cancer was diagnosed in 2015, wherever it was diagnosed, um, the pathologist should still have a report as to what the tumor type was. Was it hormone receptor positive or HER2 positive or negative? What the tumor grade was, and if the there was any consultation with an oncologist after that diagnosis, that oncologist in their documentation, and those notes should be available wherever that encounter may have been, um, that should describe the stage of the cancer, which is how large the tumor was, and if it had gone to the lymph nodes and how many lymph nodes might have been affected.
Okay, good to know. Thank you. Another question: what is the rationale for increased duration of anti-estrogen treatment? Additionally, is there a medication to use after anti-hormone treatment?
So the first part was, is there a reason to extend treatment?
Yeah, what is the rationale for increased duration of anti-estrogen treatment?
Okay. So those decisions are all based on the studies that take women who have been diagnosed with breast cancer and treated surgically, and are treated one way or another. And then after many years, the comparisons are made between the people who are treated with treatment A versus treatment B. And then you determine which group of women did better in terms of lower risk of recurrence. So if the treatment who were the women who were treated with treatment A had a lower risk of recurrence, then treatment A is better than treatment B, and that becomes our preferred treatment. So when it comes to duration of treatment with anti-hormone pills, studies like that have been done. Um, the initial studies all determined that 5 years was a very good treatment duration. It was better than 1 or 2 or 3 years, and 5 years became our standard. But over the decades following that, people tried to see, well, what if we extend that to 7 years or 10 years? And we found that 10 years seemed to be better than 5 in certain cases when the cancer is a little bit more advanced. And other studies showed that, well, if you go to up to 7 years versus up to 10 years, there's no difference. So 7 is better than 5, but 10 sometimes, not all the time, is not better than 7. You see? So depending on the case, sometimes we stop at 5 when it's a lower risk cancer. And sometimes we go all the way to 10 when it's a much higher risk. And sometimes we stop at 7 depending on the case. And that's based on those studies. I hope that answers the question. There was a
Yeah.
second part to that question, but I'm not sure.
Yes. Yep. The second part was, is there a medication to use after anti-hormone treatment?
So right now, no. Right now, we don't have any medicines that we use after that. Yeah. I would just say that maybe those lifestyle changes that we talked about, those are very important. And I would encourage everybody to consider those because they could be as effective as the treatment that we do.
Great news. One more question, not one more question, but the person wrote one more question. I just stopped taking tamoxifen after just under 10 years. This is related to what you just said, I think, but should I be nervous about recurrence now?
So I would say, should I be nervous? No, because that has never helped anybody. Um, being nervous doesn't really prevent recurrence. Having said that, I'm not trying to be insensitive. Um, you can't help feel nervous when you remember that this is what happened, that there's still a risk that the cancer could still recur. Um, but if you've completed 10 years of tamoxifen, you have done almost everything possible to make that risk of recurrence as low as possible. And if there are, and again, I don't know your case, and I think it's best to be discussed with your oncologist, but if there are no other treatments or recommendations that are known to lower the risk of recurrence, then I think you should feel confident that you've done everything possible to lower that risk and just live and enjoy your life as best you can.
Thank you. What about mixed muc- mucus? Sorry if I'm not pronouncing right. Breast cancer is the
Mucinous?
yes. Thank you. Is the prognosis better than regular ductal?
Yes, by far. Um, the likelihood that mucinous cancer would spread to the lymph nodes is a lot less, and the likelihood that mucinous cancer would become metastatic is also a lot less. Without giving like precise numbers, but it is much less likely to metastasize. It is not 0%, but it's much less likely. For example, when we recommend hormonal therapy to women with a small ductal cancer, that is, say, about half an inch, and somebody who has a mucinous half an inch, it would be fine and reasonable not to prescribe hormonal therapy because their risk is so low.
Thank you. And it was mentioned in the presentation that women less than 35 years old would be more likely to have a recurrence. Usually you see age, as being less risk factors the younger you are. So what is the thought or theory around why
So
that younger age?
yeah, so these are statistics. When you look at the statistics of recurrence of a tumor of a certain size in women who are less than the age of 35, they seem to be at a higher risk of recurrence. Um, it's probable that they develop more aggressive cancers than the general counterparts of older women. Um, I didn't want to get into too many a lot of the details. There's a little bit more about age, how that affects prognosis, and so on. But in general, statistically, somebody who's less than 35 diagnosed with breast cancer, the cancer seems to be more aggressive and more likely to metastasize. But we still treat them similarly. Yeah.
Thank you. How soon after radiation treatment ends should a person start anti-hormone therapy? Is there a time period where it would be too late to start? This is DCIS cancer treatment.
Okay. So for DCIS, um, so let's answer the question, the first part of the question. Is there any time that becomes a little too late to treat them? Um, the, as the way the question is answered, it's a bit difficult I'm sorry, the way the question was asked, it's a bit difficult to answer because when we recommend anti-hormone therapy for DCIS, we recommend it based on those studies that were done in women who had DCIS treated surgically, and some of them took the medicine and some of them didn't take the medicine. And the ones who did take the medicine had a lower risk of local recurrence. And in those studies, all the women started the treatment within weeks of finishing the surgery and the radiation. Okay? So we don't really know if you started late, does it really reduce the effectiveness? But what I can say is that in the context of DCIS, this does not apply to invasive cancer. The use of these anti-hormone medication is not a life-saving treatment. We're not trying to prevent metastatic recurrence. We're not trying to prevent death from breast cancer. We are trying to lower the risk of a local recurrence or the risk of another cancer in the other breast, of a brand new cancer. So in that context, this is what we call secondary prevention. So this is a preventative treatment. And because it's preventative, it, at least in my opinion, even if it started a little late, it's better than not. Okay. I know it's a long-winded answer, but yeah.
Thank you. I think we have just one more unless any new ones come in. Um, in general, if breast cancer comes back, is it typically worse that time around? Like, is the prognosis worse, or is that really dependent on the type and other factors?
Again, I'm going to break it down into local versus metastatic. Okay. So if it comes back and it's metastatic, yes, it is by far worse because metastatic is not a curable cancer, at least not today, hopefully in the future. But if it's we're talking about just a local recurrence, somebody had cancer, say in the left breast, they had surgery, radiation, etc., and the cancer grew back in the same breast. It is not good news for sure, but this is somebody who can still be cured. Is it worse? Yes, probably it is worse because it is cancer that has come back even after treatment. But is it potentially curable? Then the answer to that is yes, definitely.
Great, thank you. I don't see any new questions, so I'd like to thank you, Dr. Sakr, for taking the time to speak with us today and educate us and take questions. I hope that everyone has a wonderful night. Thank you so much for joining.
Been a pleasure. Thank you.